Hello everyone, this is Dr. Neela Mansoor. Today I will be talking about depression in NAC OSCE setting as well as real life cases which we encounter in our day-to-day life. This video is for educational purpose only by Starmed Medical Education Program. So before moving to the NAC OSCE task, one should know how depressed patient can present with. They can present with a variety of symptoms such as angry outburst, irritability, frustration, or crying spells. Sometimes they can present with loss of interest or pleasure in most or all normal activities such as sex, hobbies, or sports. They might present with sleep disturbances, including insomnia or sleeping too much. They can present with tiredness and lack of energy. So even a small task takes extra effort. So now what are the important things you have to keep in mind before taking the history? Number one is the age of the patient. Number two is gender. Why gender is important? Because depression is more common in female as compared to male. Then we move on to the presenting complaint. Later, history of presenting complaint. Then past medical history, past surgical history, family history, social history. And in social history, you will ask the patient, how do you support yourself financially? With whom do you live? And ask about the smoking history, alcohol, and drugs. These are the important things one should keep in mind while taking the history of a patient who is depressed. Now moving on to the task. Read the task carefully written on the door. Spend 2 minutes to formulate information, as these 2 minutes are very crucial. One should keep in mind all the differential diagnoses related to the complaint of the patient. For example, the scenario is George Smith, 46-year-old, presented to your office with low energy. Take a detailed history. And as we know, the patient who has depression can present with difficulty in sleeping, inability to concentrate, decreased appetite, etc. So the differential diagnosis for depression includes illnesses like hypothyroidism, anemia or pernicious anemia, multiple sclerosis, cancers, medications such as beta blockers, anti-Parkinsonian drugs, adjustment disorder with depressed mood, postpartum depression, substance use like ethyl alcohol, opioids, benzodiazepines, or sedatives. Other causes includes chronic debilitating diseases like diabetes mellitus and stroke. After knocking the door and formulating all the information, keeping all the differential diagnosis in mind related to the presenting complaint of the patient, then the candidate will proceed by knocking the door. Go to the examiner and hand over the sticker to the examiner. Then use hand sanitizer. Now here comes the introduction. Let's suppose the name of the patient is Mr. Smith. You will smile and say, "Good morning, Mr. Smith. I'm Dr. Mansoor. I am one of the physicians, or you can say one of the doctors on duty today." How to start taking history. If you know the complaint of the patient, you can start something like this. I understand that you are here because of whatever the complaint of the patient is. Let's suppose the patient came with a complaint of low energy or decreased appetite. Sometimes they can present with disturbed sleep. And in order to explore more about the complaint, you can tell the patient something like this. Can you tell me more about it so I can figure out a working plan that can help you? And you also reassure the patient that if you have any concerns or questions, please feel free to stop me and let me know. Then move on to the next stage, which is the history of presenting complaint. And in the history of presenting complaint, you will ask the patient about the onset, course, and the duration of the complaint. Key questions for depression. There is a mnemonic for depression symptoms: MCG caps or JAMC caps. Whatever is easy for you, you can memorize it. So M is for mood. So how is your mood? You can ask the patient. It could be low or high. And then you ask the patient about the sleep. How is your sleep? For interest, you can say something like this: are you taking interest in the activities which you used to do before? For guilt, do you feel guilty about anything? Energy, how's your energy? Are you able to concentrate? How's your appetite? Increased or decreased? Psychomotor retardation. Do you take longer time to perform a task? Then come to the suicide. Have you ever thought of killing yourself or others? Then what are the depression signs and symptoms, as we already discussed? So we have to ask the patients in detail. When was the last time you felt well? And then you say, ask the patients if he or she is complaining of fatigue. So we usually ask, how did it start? What was the course of the symptom, like fatigue? And how long did it last? And later on, you will ask about any related symptoms, and then you move on to the next. How are you feeling recently? Try to explore more causes of depression. Any loss of loved one in the family in less than 1 month? And do you take interest in the activities you used to do before? Any change in weight, like gaining or losing weight more than 5% of weight within a month, or any increase or decrease in appetite? Are you able to concentrate? How is your energy level? Insomnia or any excessive sleep almost every day? Do you blame yourself when things go wrong? Sometimes people feel down. They may feel like they may no longer wish to live. Have you ever felt like this? Have you ever had any thoughts or plans of taking your own life? Have you ever thought of harming others? Do you have any family or friend who you can talk to? Then try to explore more about the stressors, because sometimes depression can be related to premenstrual syndrome, dysmorphic syndrome. So we'll ask, is it related to your periods in case of females? And I already mentioned about postpartum depression. Sometimes, especially in the winter season, some of the patients they feel depressed. So it's a seasonal. Then any conflict in relationships, like recent divorce or breakup, and occupation is also important. Sometimes the shift work can cause depression. Then safety is very important in case of depression. Some of the patients try to harm themselves. So this is very important. It's a kind of an emergency. We have to rule out suicidal intent. And we'll ask the patient, do you have any plan to kill yourself? Or do you have any thought of killing yourself? And if the patient says yes, then you have to ask about the plan. What are the means? And sometimes they can have homicidal intent. So have you ever tried to hurt yourself or others? So hurting one own self is suicidal and hurting others is homicidal. coming to the screening of diseases which causes depression. So number one, screen for hypothyroidism. You will ask the patient something like this. Do you feel that your skin is getting dry? Are you constipated? Or how are your bowel movements? Any decrease in appetite with weight gain? Do you feel fatigue? Then move on to the screening for premenstrual dysmorphic syndrome. And you will ask the patient something like this. You feel your mood changes are related to periods, or do you feel any irritable mood before the periods, or feeling like crying or irritable before the periods? So these are the things which are related to periods and causes depression. Then screen for bipolar. Have you ever felt elated mood? Then after asking all these questions related to differential diagnosis or depression specifically, then you move to the past medical history. And then you ask the patients, did you notice any symptoms of weight gain or weight loss? Or you specifically ask question related to hypothyroidism, like have you ever had any history of high thyroid hormone or low thyroid hormone, any history of high blood sugar, or any cancer, or any related autoimmune disease, vitamin B12 deficiency, any history of chronic pain, renal failure, or chronic medical condition. Then psychiatric illness, any previous history of psychiatric illness. How about any previous attempts of suicide? Have you ever taken any treatment for any psychiatric disorder? Any past episodes of depression or mania or hypomania or mixed episodes? Have you ever been hospitalized? Any previous therapy, as I already mentioned, for antidepressant? And if he or she says yes, then try to ask what was most helpful, what medication helped you a lot, and are you on any medication for any reason, or do you take any medicine on regular basis, such as metoprolol, risperidone. They can cause depression. Steroid can cause depression, clonidine, antiepileptics, etc. Then ask about the family history. Any family history of psychiatric illness, especially mood disorder, suicide, or any substance abuse or history of abuse. So next is social history. In social history, you ask the patient, how do you support yourself? With whom do you live? Do you smoke, drink, or use any illicit drug? In wrap up, you will always say thank you to the patient. You will start something like this. Thank you for answering all my questions. And then inform the patient about his or her condition. You will say, based on what you have told me, the most likely explanation of your symptoms is a medical condition called depression. But I need to examine you first and run some tests in order to confirm your diagnosis. So, what do you know about depression? Did you read anything about it? Then explain the patient what the the depression is. It is the most common mood disorder in which you feel low, upset, and lack of energy. And it is a common problem. It is treatable. It is treatable. Explain the pathophysiology and tell the patient it is related to imbalance of the chemicals in your brain, in our brain, most likely related to decreased serotonin. Then we come to explain the complication or consequences of the condition. It affects the functionality, leads to decreased concentration and ability to work, and in severe cases in susceptible person, it might lead them to commit suicide. Workup plan includes blood work or urine. Blood work includes CBC, electrolytes, creatinine, urea to look for renal failure, thyroid stimulating hormone, random blood glucose, and B12. Urine analysis for infection or urine toxicology. Then look for any alcohol level, acetaminophen, and salicylates. We can also go for radiology or imaging like CT or MRI to rule out any organic brain syndrome. And sometimes we go for EKG depending on the cause of depression or the condition which requires investigation. Treatment. If it's an emergency, you have to admit the patient in the hospital if it's an acute danger to self or others. And treatment for major depressive disorder includes lifestyle modification, which comprises of aerobic exercises or mindfulness-based stress reduction, sleep hygiene, etc. Talk therapy like cognitive behavioral therapy or interpersonal therapy by psychologists or psychiatrists, and then medication. So medication is first line medication is antidepressant, which includes SSRI, selective serotonin reuptake inhibitors, or SNRI, non-selective reuptake inhibitors. Bupropion, mirtazapine, these are all first line. Along with that, interpersonal cognitive behavioral therapy establish a therapeutic alliance. Second line is tricyclic antidepressant, trazodone, quetiapine, augmentation with lithium, behavioral supportive therapy, and book regular follow-up. Offer assistance of social worker. And third line is monoamine oxidase inhibitors. Inform the patient about the red flags so that the patient can anticipate the side effects and remain compliant with the medication. Explain the patient about the contract between the physician and the patient. And tell the patient that sometimes when the antidepressant starts to work, the energy level improves while the mood is still low. That is why sometimes there is an increase in suicidal ideation. This usually happens within 2 to 3 weeks. You need to promise me that if this happens with you, you will call 911 or suicide hotline or call me immediately and come to see me. Offer more information by providing brochures or website links. Ask the patient every 30 to 60 seconds, does that make sense to you? Would you like me to clarify anything for you? Is this clear to you? And later schedule a follow-up appointment in 2 weeks to assess the response to this treatment or any side effects such as weight gain, sexual dysfunction. Explaining the side effect will help the patient to become more compliant with the medication. In the end, always say thank you for being so cooperative to the patient. Thank you.